Hello, everybody in Facebook land or social media land. This is Elliot Garza, and I am privileged to have a conversation this morning with Dr. Palafox here in San Antonio, Texas. Keep in mind, this is a live stream. One of the important things, you can engage, ask any questions you want. If you notice, the location is a little bit different outside of a clinic. Our event location sponsor is the Lexus at Dominion off of I-10. If you notice the nice vehicles behind us, you need to come check this place out. This building looks like a resort, so very comfortable, it's interactive. Their sales people too are very inviting to talk to. So if you have any questions about where we're at, or if it seems attractive enough to come take a walk and a tour of this place, please do so, because it was nice that they allowed us actually having a live stream video here this morning. But anybody who's tuning in, thank you for showing up and tuning in and being a follower of MD Monthly. Also, too, after the 30-minute segment, we'll still have the stream live going on for the next couple of weeks. Any questions that you may want to ask, if you missed this particular 30 minutes, feel free. Dr. Palafox is going to be available to answer anything after that as well, too. I have some preliminary questions here and to get the conversation started. But first of all, Dr. Palafox, I want to ask, where are you from?
I'm from El Paso.
El Paso, Texas.
But I've basically lived here.
You know, I have a brother.
My whole adult life.
I have a brother who lives in El Paso, and it's just, forgive me, but it's almost like it's the stepchild of Texas when it comes.
It is.
He lives over there.
HEB won't come to El Paso.
Really?
They'll go to Monterrey, but they won't come to El Paso.
Oh, wow. Well, eventually they will, I'm sure.
Yeah.
They're taking over the world, HEB.
Mm-hmm.
But my brother lives over there, so it's
No kidding.
yeah, I wish I can see him more often. It's just geographically, and gosh, the desert and everything else, and
It has hidden charm.
yes, it's nice. I went actually last year with my daughter, and the mountains are very nice. It was the first time my daughter had ever seen mountains and stuff, so we went up there, and it was enjoyable.
Did you go to Rim Road?
Yes, we drove way up there, so.
That's the best place to go.
Anyway, shout out to my brother Danny. Miss you, brother. And anyway, so I'm glad to know you from El Paso. Tell me a little bit about your history as far as your credentials, what school, education, and everything you've come from.
So I grew up in El Paso. I went to MIT. I took a year in between medical school and college, basically to just save up money, pay for applications, and then I got into the school here at the Health Science Center, which I loved. I love San Antonio. And then I basically just stayed here. You know, I did an internship in Washington, D.C., but I just hated it. It was just too cold.
Yeah.
And so then I came back to San Antonio.
Compared to El Paso, yes.
And I've been here ever since. You know, I just love it here. And so I started off in a rural practice in Pleasanton, and then I've slowly migrated towards San Antonio.
How do you like San Antonio? So how long have you been here now?
Since 1993.
Wow. And practicing?
Forever. Since 2005.
2005. Mm-hmm. And I've been honored to be working with you now probably for the past year, I'm assuming. And we got introduced through mutual colleagues, and I've been very impressed with your professionalism, especially the industry of interest that you're in. Can you tell me a little bit more about that as far as your practice?
So what I like, I'm a general surgeon, but okay. I really enjoy taking care of breast cancer patients. That's my favorite thing to do. For a short period of time, I worked in Beaumont in a group practice, and they had a large breast cancer angle. And that's when I got into genetic counseling and genetic testing, and so that's a big part of my practice as well. I really enjoy that part of my practice. The patients, the stuff that you do is really rewarding. It's very heartbreaking and very rewarding, and I think I hope that I speak to women and speak for women when we talk about this stuff, because I think that sometimes some things to do with health in women gets a little glossed over. And so this is what I enjoy doing, so this is the angle that I promote for the benefit of women.
And there's always a lot of continuing education, both on the primary physician side and the general public, which is the patient side, are always wanting to be more knowledgeable about the latest in technology. So I'm assuming there's continuing education with the specialists as well too, correct?
Mm-hmm. I read every single day. I mean, in particular for breast cancer, there's a lot of information. Mm-hmm. There's a lot of research going on. You really have to work hard to keep up. Mm-hmm. You really do.
Yeah, as far as your office here in San Antonio, how far is your reach geographically? The traveling patients very common?
I think in general it's becoming more and more common. I think the one time it's a positive to be a woman is taking care of breast cancer patients, because I think a lot of people prefer that, but not necessarily. They just want somebody who knows what they're doing and somebody that they can connect with. In terms of how far we are, I office in Stone Oak, and then I also have an office in City Base, which is where I started. And we do get patients from as far away as Laredo. I mean, they're not coming every day, but I think it may speak to hopefully the good care that we give, hopefully the connection that we can make with the patients, not only myself, but Charles in the office. And I hope that they feel like we're giving them good care. I think that they do, and I think that's why they travel.
You know, and there's a couple of preliminary questions I wanted to ask opposed to that. And so one of the questions is, what should primary care providers know about breast cancer screening?
I think we know the obvious thing. I think we know that every woman after the age of 40 or 50 needs to have a mammogram. There's a little bit more to it now. You know, with all of the research that we've done, I think we realize now that there's other things that you can do. So the new U.S. Preventative Task Force guidelines, which are guidelines, have suggested that we start screening higher risk women at the age of 45, not at the traditional age of 40 that we've been doing. And then also they suggest that maybe women should start, the average risk woman should start screening at the age of 50 and then consider doing it every other year. I will give you my personal opinion that I think it's heresy. Although it's true that the majority of breast cancers happen after the age of 50, the most life-threatening happen in the 40th decade. In my mind, what an average risk woman is you're a woman and you have breasts. And so that leads into figuring out, okay, what is a higher than average risk woman? And so I think there's a lot of things that we have to consider. And I think that the worry is that it's time consuming, but it's not so much. So there's some quick things that I ask women. I ask everybody, even gallbladder patients. Thinking about family history, you have to guide them towards mom's side and dad's side. Because I don't think people realize that the dad is an equal contributor in terms of breast cancer risk, in terms of any risk. So that's one question, and we can talk about that in a little bit more detail. The other thing I take a look at is their weight. The biggest modifiable risk factor that we have as women for breast cancer risk is our weight. If we are very overweight, I would put myself teetering on that scale right there, just to give you a personal look at it. Somebody like me would be a bit higher risk for breast cancer because we store and produce hormones in our fat. That's easy enough. You're going to weigh every patient. The other thing you should ask is how old they were when they had their first baby, whether they've had children or not, because that's a risk factor. So for myself, I had my first child after the age of 35. That puts me at a modestly increased risk.
Interesting.
Whether women have breastfed or not is a positive. So if you have breastfed children, we think that gives you a little bit of protection. It's a modest protection, but it's better than none, right? And so for women who've not had the opportunity to breastfeed, it's not a negative. It doesn't put you at higher risk, but it helps you if you've breastfed. And then the other thing is have women taken hormone replacement? Have they ever taken fertility drugs? Those things can put you at an increased risk. So if you put all of that together, that may make what you might look at as an average risk woman, put them in a little bit higher risk category. So that woman should be having mammograms every year. I still believe in mammograms every year. I frankly don't follow the USPTF recommendations, but most women have a risk factor. You know, it's either family history, frankly, it's their weight for a lot of us. And then women are having babies later and later in life, and so that factors in. And I think it's important to ask. They're quick questions. And so that may help you stratify your patients so that you know who needs a mammogram sooner rather than later.
You know, as a male, this is very intriguing as far as information. Is there a male role that, whether it's a husband, boyfriend, should take responsibility with their loved one as well to remind them to? I mean, as far as to remind the spouse or the girlfriend on these type of things. So you're saying because it takes time, and you know, investing in that time is your life, correct?
Right.
You know, so sometimes the partnership. I'm assuming the partnership is everybody's watching as far as both genders, obviously. But I guess what I'm asking is a true partnership as far as a male, supporting the wife or the loved one as far as, hey, maybe you should go get, reminders and what have you to go see your doctor or primary physician as well. Don't you agree?
Yeah, I agree with you. And I think also, there's things that we can do together as whoever your partner is, right? Not only, hey, you got to go get your mammogram. Hey, why don't we work out together? Let's go for a walk. 150 minutes a week, which is 30 minutes a day of moderate exercise is going to reduce your breast cancer risk. Maintaining a healthy weight, or at least not gaining anymore, is going to decrease your risk of breast cancer. I mean, those are things totally in our control. If I want to go out and run, okay, my husband's going to watch the kids for me, or he's going to run with me. He's not going to say, sorry, you're on your own.
Yeah.
Because then it's almost impossible to do it. Everybody has the constraint of time. You just gotta figure it out. Everybody's got 15 minutes, right? So if you can find 15 minutes twice a day, there's your 30 minutes. And if your beloved can help you in that, why don't y'all do it together?
Here's another question I want to ask. What should primary care providers tell women who want to have bilateral mastectomy?
So this is sort of a hot topic because over the last few years we've seen in the medical community that women want to have bilateral mastectomies. I've had a few women that don't have cancer that just want to have them removed because they're afraid, right? Okay, so that's one category of patient, but specifically in this case, what I'm talking about is women who've been diagnosed with breast cancer on one side, and then they say, you know what, just take them both off. I don't want to worry about this. It's not helpful, and I think it's important to get that message out. Based on studies that we've done to date, the only group of patients that truly lower their risk of breast cancer by having both their breasts removed is people who carry a BRCA mutation, people who carry the breast cancer gene. That's the only group. The rest of us that don't carry the breast cancer gene see no benefit in having both of them removed. You can still get breast cancer even though you don't have breasts. Angelina Jolie is the most famous recent example. Now, she's a BRCA gene carrier, so her risk was significantly reduced. She can still get breast cancer even though she has implants and no breast tissue. And so for women that are not gene carriers or don't have a risk of it, like they don't have a strong family history, there's no benefit. It's one thing if you want to do it because you want them to look the same on both sides, okay, but there's no benefit in terms of your breast cancer risk by having them both removed. And I think that's an important discussion to have with patients because they may have a huge surgery and then in 10 years they may get breast cancer anyway and they didn't benefit from it. So you have to put everything into perspective for patients.
I'm actually looking at the live stream right now just to see if there's any additional questions. There's a gentleman actually is praising you for your work. God bless you, and we wish we had more of you. Keep up the good work. Victor Ramirez in the Rio Grande Valley, I actually know him. So yeah, there's a lot of support in what you're doing. There's people who are cheering your practice, your industry, and you type of physicians on because, the fight against cancer is so relevant and.
Everybody's touched by it too.
Everybody's touched. My mom, my aunt, so we've all, someone somewhere, we've had experiences, unfortunately, that we've had to deal with it.
Right.
So
right.
It works out.
And the second a woman gets that diagnosis, the second they hear they have breast cancer, they're convinced they're going to die. And that's a very hard emotion to walk back, and so it's hard for them, and we have to recognize that okay, maybe I do this every day. I see so many survivors, so I know patients are going to be okay, but they don't know it, and they think, okay, this is it for me, and I feel bad for them. You shouldn't feel like that, and it takes a little bit to get that feeling, walked back and realize, okay, it's not easy, but I'm going to get through it. You know what I'm saying?
Exactly.
That's hard for them. It's hard for their families too, but that's what we try to help them out with.
Well, continuing education, preventive health care, which complements preventive health care, self-diagnosis and preliminary tests and everything else. It's always changing. The evolution of medicine is always changing. And from the point that you started to where you're at now, you can attest to that too as well, as far as what, the genetic testings and everything now that you're providing.
Right.
That was never provided 20 years ago.
Right.
So there's a lot more that's happening. Even after the fact, even survivors. One of the questions is hidden scars. What is a hidden scar?
So hidden scar is it's a certification for surgeons, right? But really what it is, it's based on a movement.
Okay.
And the movement is, what we used to do as surgeons, honestly, is we made the incision for the convenience of the surgeon. So if a patient had a tumor, like, let's say out here, you'd make the incision out there. It's not so beautiful in terms of what it looks like afterwards, especially after radiation. And so what hidden scar teaches you, or teaches us as surgeons, is to hide the scar. Because then you don't have a daily reminder of what you went through. You can look in the mirror and say, okay, I never had breast cancer. I'm not saying to brush it off or ignore it. I'm just saying that you don't have to have that on your body. And so what hidden scar means is you're just putting the scar in a cosmetically pleasing place.
Okay.
So what I personally do is I put the scar in the inframammary fold. So it's sort of at where the underwire of the bra goes, and you just never see it. And it takes a little doing. I mean, it's technically a little bit more difficult because in terms of the operation, because I'm working in a smaller space, and I have to really get down. So it adds a little bit of time. But I mean, it's worth it, because then they come in and they say, okay, well, let me look at your surgery, at your incision, and they're like, go ahead, and you don't see it. I mean, it's beautiful, you know, and I realize that when women they're in their diagnosis and they're like, look, just let's get through this. I don't care what it looks like, but it matters. It does, because you want to be the same person you always were. You know, you want to be that same person for your family, and the truth is, up to a certain extent, you're never going to be, because you're a breast cancer survivor, and there's the cross to bear, I think, for cancer patients, because they're always worried it's going to come back, right? We don't want that for them, but if we can take away a little bit of the daily reminder that they're that survivor, then that's nice, you know? And so it's very cosmetically pleasing. And patients will tell me, I don't care about the scar, Dr. Palafox, but I do. I care, because later on, I do believe it's going to matter to them. And there have been studies that have shown that the physical self-confidence helps a lot with your mental self-confidence, and then you know that you're going to survive, you're going to live the same long life you were going to live, even though you had breast cancer.
Yes. You know, I learned a lot being in the industry that I'm in, as far as a medical publication and our platform on our digital presence, moving into that space and different markets as well. I'm an expert in none, but the thing is I have different knowledges of different, it's very intriguing, you know, to get this information out and how important it is. And I tell people all the time, even on the Google platform, 1 out of 20 keyword searches is health related. So there's a huge influx of information out there that the general public is wanting to know, to where they're even asking their primary physicians certain questions as well too. And it's very important that we get this type of information out there. How long does it take to figure out if someone needs genetic testing?
I think that so one of the problems that I think that primary care physicians have is their lack of time.
Okay.
I mean, they're trying to cover all kinds of things. They have to ask people if they have smoke alarms. They have to do smoking cessation. There's a lot of things to cover for a primary care provider, right? So they're very limited on their time. But there's just a few sort of screening questions that I think one can throw into the mix to figure out if a patient is higher risk or if they need genetic counseling or genetic testing. And so what I ask patients about is, and again, I think you have to point it out because people feel like it only comes from their mom's side. Ask, on your mom's side or on your dad's side, does anybody have breast cancer? It's not enough to stop there though, right? Because the cancers that are associated with, for example, the BRCA mutations, there's 8 cancers. So ask them, anybody with breast cancer, anybody with ovarian or uterine cancer, anybody with colon cancer, anybody with pancreatic or prostate cancer. A lot of people don't realize that these cancers are all intermingled, because having a BRCA mutation not only makes you higher risk for breast and ovarian cancer, it also makes you higher risk for pancreatic cancer if you are a male carrier. Some people think men can't get these mutations, but they can. If your mom or your dad has it, they have a 50-50 chance of passing it along to each one of their children. So you can have a male that, let's say, has a strong family history of breast cancer. If he carries the mutation, he can pass it along to his children. He can get male breast cancer. And so you have to consider a bit more than just the breast cancer angle. So for example, I had a patient that came to see me. She didn't have any breast cancer history. She had 7 or 8 men in her family that had pancreatic cancer. And at a relatively young age, under the age of 60. And I thought, well, we should test you. So she had a BRCA mutation. She was at significantly higher risk for breast cancer, ovarian cancer, pancreas cancer. And pancreas cancer, for example, we don't screen for. We're not looking for it. If you get it, you get it. We're not doing a test like a mammogram to see if you get pancreatic cancer. So it was a huge benefit for her, and it wasn't immediately obvious. As it turns out, her family was just mostly men. There weren't very many ladies in her family for whatever reason. And so it showed up, that mutation showed up in her family as pancreas cancer. She was a higher risk for breast cancer.
Wow.
But she was the only daughter among like 7 brothers or something, if you see what I mean. So you do have to ask these other questions, but you can still blow through them in a relatively quick fashion. Or there's a family history screening questionnaire. It's got like 12 questions. Throw it at the patient, have them fill it out, and then if they meet the criteria for genetic counseling, we'll do all the details. I'll ask them everything about their life.
Do you find it more that, I mean, is the general public more aware of genetic testing, that they're asking for it as well too? Or there needs to be more awareness about it, genetic testing?
I think that Angelina Jolie made it more obvious, but I think that was really just the tip of the iceberg, and I think people just concentrate on, is it a breast cancer in my family, and is it on my mom's side? So I think there does need to be a little bit more education, because I don't think that people really realize how many questions you can ask and how much more of a risk there is. I think we need more education.
Here's another question. Janine Dixon, who's always a loyal follower, have you seen higher breast cancer risk in certain ethnicities?
Yes.
Tell me about that.
Okay, so in the Asian population, they have a lower risk than average. If you go just by ethnicity, the people with the highest risk for breast cancer in general are white women.
Okay.
There are certain populations, though, that have maybe not necessarily a higher risk, but they have a different risk. The most glaring example is African American women. African American women tend to be diagnosed at a younger age. They tend to be triple negative, which is a more aggressive form of breast cancer that's more difficult to treat because we don't have anti-hormone therapy for it. And they, for a wide variety of reasons, they're diagnosed at a later stage. They don't get the same health care. And so that's one population. The Hispanic population as well, although if you look at the populations, we have the same incidence as the white population. We, again, tend to get diagnosed at a later stage. There's certain mutations in the Hispanic population that we don't see in the white population.
Okay.